Hi, my name is Fabian Emura. I'm professor of medicine in gastroenterology at La Sabana University here in Bogota, Colombia, and I'm very pleased to participate in this important meeting. My talk is on quality parameters in EGD. Is this fiction or reality? My objectives are to review current intra-procedural EGD quality parameters, to highlight the lack of consensus on EGD completeness, to explain the rationale and demonstrate a systematic photodocumented EGD, and finally to share the results of a feasibility study regarding the completeness rate, the inspection time, then NDR of complete photodocumented EGD, which is actually a study that we did here in my institution. Intraprocedural EGD quality parameters are very much published time and again by major societies as ASGE. Here are 9 listed, and interestingly, among those 9, out of 9 indicators relates to Barrett's esophagus or GI bleeding, and there is only one indicator that says which is the number 5, that says complete examination of the esophagus, stomach, and duodenum, including retroflexion in the stomach. Update recommendation published in 2015. This same group of experts from ASGE additionally set a performance target of 98% of cases of complete examination. However, it is important to say that Barrett's prevalence in routine EGD is only 1.6% of cases, and it goes up to 8.5% when patients are older than 50 years old. And also important to know that GI bleeding is a very rare diagnosis in elective endoscopy. That means that completeness is the only one indicator recommended when Barrett's esophagus and GI bleeding are not encountered. The criticism regarding these indicators is, number 1, there are too many indicators, and that these indicators actually have not been adopted in value-based care plans, and therefore, currently, unfortunately, I need to say that quality parameters in EGD are a fiction and not a reality. In addition, there are currently no reliable performance measures to gauge the completeness of an upper endoscopy examination. There are also unsolved questions like, what is a complete visualization? It is to see all or to photodocument all, and what is all and what is complete? Well, there are already published potential indicators of completeness. First is the photography of the bladder ampulla, also a cutoff time of 7 minutes, and recently the complete photodocumentation of 28 described endoluminal areas. The general perception, however, regarding these 3 indicators is that the bladder ampulla photography is too trivial, that the 7 minutes cut of time not necessarily mean that all the mucosa has been evaluated, and that completed photodocumentation of 28 described areas needs training, is very time consuming, there are no feasibility reports, and there are no benchmarks also reported. I think that benefits of complete photodocumentations are numerous. I have listed some of them here. Number 1, complete photodocumentation ensures completeness, and this is by intuition. Number 2, reduces the risk of missed lesions. Complete photodocumentation can act also as a legal record in order to help professionals from medical legal issues, and also improves quality and patient care. 20 years ago, it was published that At least 4 images in retroflexion and in 4 images in direct view should be taken according to these ESG recommendations. Recently, this has been reviewed, and the ESG has increased from 8 to 10 images. There are some also publications from the United States that includes the esophageal introitus, the proximal, mid, and distal esophagus. But actually there is no current consensus on how many images should be taken. If you look at the Japanese routine endoscopy, you will find this interesting study report more than 3,900 routine EGDs in which 60 images were taken from every case, 20 images from the hypopharynx and esophagus, and about 40 images from the stomach and duodenum. This interesting study divided 3 groups: the fast speed endoscopists who complete the inspection time in less than 7 minutes, moderate speed 7 to 10 minutes, and the slow endoscopists more than 10 minutes. And if you see, there were no differences in the neoplasia, the detection rate among the groups. To set a middle ground between Europe and the United States and Japan and other Asian countries, the World Endoscopy Organization has recently published this interesting article, which is Principles and Practice to Facilitate Complete Photodocumentation in EGD, and is basically composed of 28 stations that has been break down according to endoluminal anatomy principles. Actually, the Gastric Cancer Association from Japan has divided the stomach in 4 walls: the anterior and the posterior wall, and also the greater curvature and the lesser curvature. And I have proposed that the upper GI tract should be divided in hypopharynx, esophagus, stomach, and duodenum, and the stomach and other regions like the lower third, the middle third, the upper third, the lesser curvature. So taking all this into account, the result are 28 areas that has a number and a name. Just let me start saying that the hypopharynx examination is quite important. Here in the hypopharynx are located more than 87% of cancers comprising the oropharynx and the hypopharynx. The most frequent location are the piriform sinuses that accounts up to the 78% of all cases. The esophagus can be photodocumented in 3 stations: the upper, the middle, and the lower third, according to these landmarks: the left main bronchus and the left atrium. These landmarks were already published by us, and they are located at 25.8 centimeters from the incisors, the left main bronchus, and the left atrium at 31.4. So going down the AG junction, which is important to be recorded in esophageal axis, which locates the anterior quadrant between the 9 and the 12 o'clock. It is important to keep in mind a proper orientation here, because according to this interesting article, more than 0.5% of all cancer lesions are located between the 2 and 5 o'clock arc. The antrum, it is important to be photodocumented starting from the pyloric channel and going in a clockwise manner, starting in the anterior wall, then the lesser curvature, then the posterior wall, and the greater curvature in a clockwise manner, as I mentioned before. And the gastric cancer incidence here, I mean the early cases here, are 48% of all cases according to our data here in Colombia. If we pull back our scope about 10 centimeters, we'll find the lower third of the gastric body. And again, clockwise photodocumentation, it is important, starting in the anterior wall, then the lesser curvature, the posterior wall, and the greater curvature. Here there is a lesion in the anterior wall, area number 11 in the gastric cancer. Incidence here in early stage is about 26%. Pulling back again the scope, we will find the middle body that is composed of other 4 stations. Here as a representation image of early gastric cancer in the posterior wall of the middle gastric body. The early gastric cancer incidence here is about 11%. The examen continues in retroflexion view, examining the upper third, which is also composed of 4 stations, 19, 20, 21, and 22. The gastric cancer incidence here is about 15%. Here you can see a TUSI lesion, which is actually a CWAR2 cancer invading the mucosal layer. Then the lesser curvature that should be evaluated in retroflexion, because in retroflexion the camera is almost perpendicular to the lesser curvature. The exam starts from the upper third, area 23, the area 24, the middle third, the area 25, the lower third, and finally the entire incisura angularis is captured in the station 28. The early gastric cancer incidence here is 58% when the radial orientation is evaluated. Finally, complete photodocumentation goes to the duodenum to photodocument stations 27 and 28. At the end, we do have kind of this reconstruction of our entire mucosa, and the important clinical value of this examination is that every area is unique and alphanumerically coded. Images are taken overlap. That means that there are no blind spots between them. The exam is sequential. That means it starts from station 1 and ends up in the station 28. Allows cross-examination by our peers. We actually can read endoscopy, take a look of other exams and diagnose other exams as well. Is the closest definition of a complete exam, and I think constitutes the basic fundamentals for artificial intelligence. Here is also another reconstruction of complete photodocumented EGD, in which we can diagnose patchy redness in the antrum and also in the lesser curvature, and a 2A plus 2C lesion in the area 13, that is the posterior wall of the lower third of the stomach. Or if we do magnifying endoscopy using BLI or MBI, we will identify here a demarcation line and microstructure and micro vascular irregularity, which makes the diagnosis of an early gastric cancer. I think that complete photodocumented EGD is feasible, needs training. My personal opinion is that photodocumented EGD is a quantifiable EGD parameter that can be used as a quality indicator. Just let me show you a video.
This non-edited real-time complete examination of the upper GI tract starts at the hypopharynx, area number 1. The upper esophageal third is examined at natural axis, where the left main bronchus locates at the anterior wall, area number 2. Then, having the left atrium landmark as distal reference, the area number 3 is captured. The distal esophageal third, area number 4, and lastly the EG junction is observed, area number 5. In the stomach, the examination starts with the scope in direct view with a close-up image of the pyloric channel, area 6. Then, the antrum is examined clockwise, beginning at the anterior wall, area 7, the lesser curvature, area 8, the posterior wall, area 9, and the greater curvature, area 10. The scope is pulled backwards to examine the anterior wall of the lower third, area number 11, the lesser curvature, area 12, the posterior wall, area 13, and lastly, the greater curvature, where the epithelial transition zone is frequently seen, area 14. Then, the anterior wall of the middle gastric body, area 15, the lesser curvature, area number 16, the posterior wall, area 17, and the greater curvature where the gastric folds are captured horizontally, area 18. The greater curvature of the upper third, area 19, and here the exam continues in retroflexion view, capturing the anterior and posterior walls of the upper third in one shot, area 20, then the fornix, area 21, the posterior aspect of the cardia, area 22, and the lesser curvature is examined with a close-up view of the upper third, area 23, then the middle third, area 24, the lower third, area 25, and lastly, by rotating the small wheel clockwise, a view of the entire incisura angularis is captured, area 26. Thereafter, the scope goes into the duodenal bulb, area 27, and finally, the second duodenal portion is captured with the ampulla of Butter, usually located at the superior left quadrant, area 28. This type of examination can be performed in less than 3 minutes.
So we conducted a feasibility study here in our unit in Bogota, Colombia, and evaluated completeness rate, the inspection time, and the NDR, which stands for neoplasia detection rate, in 128 consecutive patients, and we do evaluate differences between expert and trainees. Participating endoscopists were an expert with more than 12,000 complete EGDs, photodocumented, and the trainees were first-year fellows that underwent step-by-step training, comprising a review of the alphanumeric nomenclature, training and diagnosis of early cancer. They had at least 50 hours in an EGD simulator, as it is shown here, and they complete further hands-on training with 20 completed examinations under close supervision. Completeness was defined as a record of 28 areas representing the 28 endoluminal areas according to the protocol of the WEO. An incomplete examination was defined as a record of less than 28 areas. Inspection time was defined as a time between photodocumentation of area 1 and area 28. Sequential photodocumentation were the records in which the consecutive registry of 1 to 28 was obtained, and NDR was defined as the total number of neoplasia on biopsy per group, including esophagus, stomach, and duodenum. The results completed for the documentation was achieved in 90%, 94% of cases in the group and 92% in the trainee group. There were no difference between the groups. The median inspection time on the expert was 4 minutes and 7 minutes in the trainee. Regarding NDR, it was 3% in the expert and 5% in the group. There were no differences among the groups. In conclusion, ladies and gentlemen, I need to say that the use of EGD quality parameters is still, unfortunately, a fiction. Number two, the WEO complete photodocumentation protocol was supposed to be the light in the tunnel. Complete photodocumentation and I think that this measure can be adopted as a quality indicator, improving the overall quality of EGD. And finally, please save the date for the third World Congress of Endoscopy, organized by WEO.
Dr. Fabian Emura, thank you so much for a truly fantastic lecture, teaching us, taking us through the basics of EGD, the quality, and telling us what is fact and what is fiction. Thank you very much.
Can I ask a question, George?
Yes, yeah, sure, please. I mean, I think Dr. Emura is not on the panel, I hear, George.
No, but the thing that strikes me about his data is that between the trainee and the expert, the only difference is number of minutes that the expert took. It was much shorter, but otherwise the findings, etc., were identical. So, I mean, I keep wondering whether trainees need to be taught how to do a quality endoscopy and going through the stages, yes. But it would be good to know if the way we train people is going to be any different from trainees under his scheme of things. You know, whether there are variations from center to center.
That would be, but I think what he was trying to, because those pictures were available, all 28 of those areas and the views, that, it was, he even talked about artificial intelligence. I was just wondering whether it's going to a phase where with the technology available, things become much easier and better.
Yes, I suppose the other thing is using narrowband imaging that's an area where people are not really taught how to make assessments. I think we probably need to be very much clearer on that.
Yep, certainly, yes.